So this is the case. Now let's talk about it. What you see is a periapical radiograph. It shows the bone loss. What you're seeing in red is the actual bone level. I'll show you the CBCT section as well, but this is the actual bone level, more or less. Gives you an idea. What you see in green is the maximal potential for regeneration, or the most likely, in the ideal scenario, level to which the bone can grow back once the tooth is taken out. So this is just a PA. Now let's look at the section of the CBCT. Not very clear, but you get the idea. Same thing. This is the bone and it drops here all the way. Then it comes back, but you can see the measurement here. It's 10. It's slightly overestimated. I think the actual defect was 9ish something, whatever. There are other sections as well, but this is just to show you, just to give you an idea. Okay, now what did we do? Now this is my bone grafting, which I'm doing. A lot of people in such cases would use resorbable, non-resorbable membrane, or they would use titanium or this or that or there. Of course, I've done that. I have tried to now move away from non-resorbable membranes, because in a lot of these cases, not a lot of these cases, but yeah, in a good number of cases, let's say in 30% of cases, there is a potential for reopening of the flap, and then it's a nuisance. So I try to stay away from the non-resorbable if I can. I've used it in past, but now I try to avoid. Especially now, remember, when you're dealing with a site which has teeth versus an edentulous site. When there are teeth involved, it can be more challenging. Why? Then you have to see how your flap is going to remain tightly closed, how you're going to suture it. Okay. So a few things to notice. One, we have particulate bone, so the blood supply will be faster versus a block graft. And there is a part of, like, not too much, but there are scrapings, autogenous scrapings in there, okay? Another thing that I would like to mention here, I like to use if I'm going to use any autogenous, if I'm saying if, I like to use the same site. You see, that's my goal. Anybody who's been following my posts, I want to avoid a second surgical site if I can, and there are reasons for that, but for now let's just focus on this case. So basically what we've done is we've taken some scrapings, we've mixed it with allograft, only allograft, and few particles of xenograft. Okay, for example, let's say this particle, xenograft. Okay, mostly it's allograft, bulk of it is allograft, little bit of autogenous, and very little xenograft. Once it's done, then we cover it up with the resorbable membrane. This is the first layer, and I will put a second layer of resorbable membrane on top of it. But notice one thing, the shape even right now, it's rather than being completely round, it's more rectangular. Okay, if you can see it. Why? It's because it is crazy amount of bone. There is so much bone, like, it's amazing. And what I will do when I will put my resorbable membrane on top, I will very gently from the apical part push the bone slightly upward, like in this way, going up coronally, because that's where we need the most bone. Then shaping the membrane is critical, making sure the membrane covers it perfectly, going beyond the defect. Then I like to use a second layer of membrane. So for example, I'll get a very big membrane, I'll section it into 2 pieces, and I'll get a second layer, put it on the first layer, then I'll close it up. Okay, so the other important thing which I almost forgot, what is my limiting factor? My limiting factor, actually I did mention on this one, is the bone level on the adjacent teeth. So in the ideal world, the maximal bone in theory we can get from here to here, that's the max. And vertical regeneration is typically, we say it's unpredictable. It's not very predictable, meaning if you do 100 cases, you cannot say I'll get it on 80 to 90 all the time. Or at least most people in the world can't. Okay, that's why in the AAP papers, Max Fax people, whoever is doing, they generally say it's unpredictable. So this was the situation, and then this is how we ended up with. So you can see the bone quality looks really, really good. And look at the bone level. It's almost from, like, it's perfect. It's just come back the entire way. This is where I've removed a little bit of blood to make sure it, like, we can see it nicer. And this is my implant. So you can see once again, the width, the height, it's almost come back 100%. So the idea is, if I was to put it in a summary, your flap design, not just design, the passiveness is critical. It's critical. When you pack bone, you don't pack it too tight. I've made that mistake. I used to pack it like crazy tight. Doesn't work. It leads to resorption. How do you stabilize the membrane? People use tacks. That is amazing. Yes, I have done that. Screws, I've done that. Now, most of the time, I would suture it up. So, or sometimes I don't stabilize it, but it's not very often. So it's very important that small things. And lastly, before I forget, the flap, when I say passive flap, what do I mean? What I mean is my flap would lay down, and when I'm suturing it, I don't have to force close it. It's as if it's almost touching on its own. So if I'm giving vertical release, I close my vertical, I close my second vertical, and my flap wants to close on its own, even before I've given any sutures. That's what I mean by passive flap. So if there is any tension in the flap, then it means it will open up. So typically when I add bone, I add crazy amount of bone. Some cases, like, I take a lot of pictures. Some cases, probably at the time of closure, I ended up with 13 to 15 millimeter ridges. But alhamdulillah, they stayed closed. So passiveness is important, and the handling of tissue is really important. That's it for now. I have a case coming up, so I'll say goodbye. Have a good one. Take care. Bye.